So there are certain important, as I told you, ST elevation MI you can localize, but there are exceptions in which although there is no ST elevation, still it will give you a localizing value. What are those exceptions? So here you can see that this patient is coming with acute chest pain, but there is no ST elevation here. It shows anterior ST segment, anterolateral and anterior anterolateral ST segment depression. But the very crucial point here is the ST elevation in AVR. So in the presence of anterior ST segment depression, if you have ST segment elevation in lead AVR, it means a critical left main lesion. Critical left main lesion. So although this ECG is not very dangerously looking, some amount of moderate ST segment depression in some leads, this is the most ECG of all I have showed you. So this is a critical left main occlusion, and here the patient should be sent immediately for a coronary angiogram or the left main occlusion intervention. So this is how we can see this. We can locate the most dangerous left main occlusion by ST elevation in lead AVR. So once again, in addition to this, you can see that I have a ST segment depression anterior leads. I have a ST elevation in AVR. Okay, I can diagnose left main. But if the ST depression is occupying more than 5 leads, you have ST segment depression with a lead AVR ST elevation. It not only means a left main occlusion, it also means the patient has got triple vessel disease. So ST elevation with few leads ST segment depression is a pure left main lesion, but ST segment depression is more than 5 leads. It shows that it is a ST segment depression, multiple leads with AVR elevation, ST. It is a triple vessel disease with a left main lesion. So what is the importance of the AVR? We hardly look at. With anterior ST elevation, it indicates proximal LAD. Here, the AVR elevation is less than V1. Whereas in anti-segment depression of a left main lesion, AVR is elevated. Here, the AVR elevation is more than V1. With anterior and inferior ST segment, multiple leads are showing ST segment depression. If the AVR is going to show the ST elevation, it means triple vessel disease and left main lesion. In all these conditions, on the basis of AVR alone, you can send the patient for immediate coronary angiography. So that is the importance of lead AVR. The second important critical occlusion without ST elevation is called Wellen syndrome. In Wellen syndrome, the patient may come to you with a history of chest pain few days back or yesterday, but today he may not have chest pain. And today he may be completely stable and he just came for a routine checkup because he had a chest pain yesterday. When you take an ECG, the ECG may show mild ST coving and a T wave inversion or a deep symmetrical T wave inversion in V2, V3, V4. And this type of ECG changes are called Wellen syndrome. And this type of ECG changes, valence A is coving and T wave inversion, whereas the valence B is a symmetrical T wave inversion. So when these ECGs are present, although the patient is not having chest pain now, it indicates a proximal left-handed descending artery and the patient should be immediately sent for coronary angiogram. So this is called valence sign. Although there is no ST elevation, this patient should go for immediate coronary angiogram. And the next sign is called D Winter sign, very famous sign, which is likely to be equivalent to ST elevation MI. If the patient has got a short ST segment depression, plain ST segment depression with a very tall T waves. You can see a very tall T waves with a basic ST segment depression. So once again, this is called D Winter sign and a classical ST segment depression with a very tall T wave. And once again, D Winter sign is a very critical or a total left-hand descending artery, and this patient also should go for early coronary angiogram. So these are the exceptions that although you don't have an ST segment elevation, the patient should go for immediate coronary angiogram in the anterior wall or one anterior ST segment depression with the AVR elevation left main, anterior segment depression, multiple areas depression with the AVR elevation, it is left main with a triple vessel disease, and deep symmetrical T wave inversion V2, V3 for valence sign, or SC segment, mild SC segment depression and a very tall T wave is D-ventus sign. In all the 4 situations, although it is no anterior ST elevation, the patient should go for early coronary angiogram. Now we come to the inferior wall infarction. The inferior wall can be supplied either by the right coronary artery or the left circumflex artery, depending upon which artery is going to give rise to posterior descending artery. That means your inferior wall infarction can be caused either by right coronary occlusion or by left circumflex occlusion. Then how the ECG will, from the ECG, how are you going to predict whether the right coronary is obstructed or the left coronary is obstructed? So whenever there is ST segment elevation in inferior leads, you must carefully see whether ST elevation is more in L3 than L2, then it is likely to be a right coronary obstruction. In the right coronary occlusion, if the inferior wall infarction is to right coronary, your ST elevation in inferior leads will show more elevation in L3 than in L2. Contrast to that, in inferior lead ST elevation, your L2 has more elevation than L3. That means you are leading with a left circumflex inferior wall infarction. So this is how first we localize whether it is a right coronary inferior wall infarction or a left circumflex inferior wall infarction, depending upon which lead is showing more elevation of these 3 leads. So now once again, if I have ST elevation more in L3 than L2, I am diagnosing a right coronary lesion. Having diagnosed right coronary lesion, I must know whether my right coronary lesion is proximal or distal, just like we told you about the left descending artery. So any proximal right coronary lesion will involve the most important proximal branch, which is a right ventricular branch, so which supplies the right ventricle. So any proximal occlusion of the right coronary artery, which will involve the artery to the right ventricle. That means you not only will have inferior wall infarction in the terms of ST elevation in L2, L3 AVF, and L3 is more than L2. This will locate your right coronary artery. Whereas if you have additional right ventricular infarction shown by ST elevation in lead V4r, it indicates that you have a proximal RCA lesion proximal to the right ventricular branch. Because of that, you have the right ventricular infarction. So inferior wall infarction plus right ventricular infarction indicates it is a right coronary lesion, a proximal right coronary lesion. Then, of course, if there is a posterior wall is involved, because the ST vector is going to go towards the posterior wall, your V1, V2, V3 will show anterior ST segment depression. So in all acute inferior wall infarctions, you must look at the anterior wall to look at whether you have a proximal LAD lesion or you have the distal, in addition to that proximal LAD occlusion with a right ventricular infarction. It means a right proximal right coronary action. Anterior ST segment depression will tell you associated posterior wall infarction. So inferior wall infarction, first you have to locate the right coronary artery by looking at ST elevation more in L3 than L2. Having located right coronary artery, you must look for whether there is a additional right ventricular infarction in the presence of ST elevation in lead V4r. So this will tell you not only inferior wall infarction, but there is additional right ventricular infarction because of the involvement of the right ventricular branch. So that means the occlusion has to be proximal to the right ventricular branch. In addition to this, we must also look at the anterior chest leads for a reciprocal depression of posterior ST segment elevation. So if the patient has got anterior ST segment depression, it means he has additional posterior wall ST elevation or posterior wall infarction. So having diagnosed right coronary lesion, you must look for right ventricular infarction as well as posterior wall infarction, looking at lead V4r and anterior ST segment depression. Look at the ECG here. We have ST elevation L2, L3 AVF. L3 has more elevation than L2, so it is likely to be right coronary lesion. Then I look at lead V4r. The lead V4r is showing ST segment elevation. So in addition to inferior wall infarction, I have a right ventricular infarction, which means the proximal branch of the right coronary is involved. So the lesion has to be proximal. So right coronary artery infarction, inferior wall infarction plus right ventricular infarction tells you there is a proximal RCA occlusion. Sometimes the ECG may not have the right side leads. People who have recorded only the conventional 12-lead ECG, even from the 12-lead ECG, even in the absence of right side lead, it is possible to diagnose right ventricular infarction and also the proximal right convolution by looking at the very important ECG sign of what is known as disparity between the ST segment between V1 and V2. Discordant ST segment depression between V1 and V2. The V1 is not only an anterior lead, but it's also the right sided lead. So both when right ventricular infarction and posterior infarction are coexisting, the posterior wall infarction tend to produce ST segment depression in V1 because it's an anterior lead. And right ventricular infarction will tend to produce ST segment elevation in V1 because it's a right sided lead. So net result, two opposing forces, the ST may be normal in V1. Whereas in V2, which is a purely anterior lead, so there is no impact of right ventricular infarction on V2. So V2 representing purely an anterior lead will show only the pure posterior ST segment elevation representing as the anterior ST segment depression. So it will purely show only the reciprocal depression and not the influence of the right ventricular infarction. So net result, what you have will be a gross disparity of the ST segment depression between V1 and V2. So the 12 lead, this sign itself is good enough to diagnose additional posterior wall infarction and right ventricular infarction. So it can tell you that the patient has got proximal right convolution. So in all inferior wall infarctions, not only look at the, if you don't have the V4r, for example, in this patient, V4r recorded, then V4r also shows ST segment elevation, confirming that this sign is definitely due to associated inferior wall and right ventricular infarction. So always look at this discordant ST segment depression between V1 and V2. In contrast to that, you can see once again, I have a inferior wall infarction, L3 in inferior wall infarction, but here I have a similar ST segment depression V1 and V2. There is no discordant between V1 and V2 as far as ST depression is concerned. That means here the V1 is representing the pure reciprocal change of the posterior wall, and it is not getting elevated because there is no associated RV infarct. So when there is a concordant ST segment depression in V1 and V2, it indicates there is no right ventricular infarction. So right convolution is likely to be distal without the involvement of right ventricular branch. Right. Now we come to the right convolution which is distal, like is here. Right convolution which is distal to the right ventricular branch, That means you have inferior wall infarction without the involvement of the right ventricle. So here, because the right ventricular branch is escaped, you have only the inferior wall infarction, but there is no right ventricular infarction. So lead V4r will not show ST segment elevation. It will show horizontal ST segment and upright T wave. Normal ST segment and upright T wave. Here you can understand why in right coronary artery lesion you have L3 elevation is more in L2, because this portion of the inferior wall, right side portion of the inferior wall, is more involved in right ventricular, the right coronary inferior wall infarction, because your right coronary is coming like this. So the inferior wall infarction will affect more of right portion of the inferior wall. So L3 being the right sided lead will have more elevation in L3 than L2. But if the right ventricle is involved, you will have ST elevation lead V4r. But in this infarction, you must always look at anterior chest leads to diagnose additional posterior wall infarction in the presence of anterior ST segment depression. So look at this ECG here. L3 shows more elevation than L2. So having diagnosed right coronary lesion, I must look at lead V4r. The lead V4r is not showing ST elevation, but it is showing a normal ST segment and upright T wave. So this is a distal right coronary lesion. It's a distal right coronary lesion. So that decides whether it is a distal RCA or a proximal RCA. Then we must also know from the ECG whether which system is dominant, whether it is a right coronary system which is dominant or the left coronary system is dominant. The dominance of coronary system is decided by which artery is going to give rise to the posterior descending artery. The posterior descending artery is given by right coronary artery. The right coronary is dominant. The posterior descending artery is going to come from the circumflex. The left circumflex is prominent or the dominant. So how to decide that? So whenever you have, for example, here you have ST elevation is more in L3 than L2. So immediately you diagnose it is a right coronary lesion. Right coronary lesion. So in addition to this, you must look at the lateral leads. In the presence of right coronary inferior wall infarction, if lateral elevation, V5, V6 elevation is more than 2 millimeters, it indicates not only it's a right coronary infarction, this circulation is right coronary dominant. That means posterior descending artery is also coming from the right coronary artery. So in addition to that, you can look at that beautiful sign here. You can see the sign I have told you previously. You have a significant ST segment depression in V2 and there is almost no ST segment depression in V1. So this discordant ST segment depression also tells you it is an inferior wall infarction, lateral wall infarction because of the right coronary dominant. It is a posterior wall infarction because of the ST segment depression V2. It is also right ventricular infarction because there is a disparity of the ST segment between V1 and V2. So it is going to be a very high risk inferior wall infarction because the areas involved are inferior wall, lateral wall, posterior wall and also the right ventricle. So this immediately gives you, although it is inferior wall infarction, this is a very high risk inferior wall infarction because of multiple areas are involved. So this is how just looking at the first ECG itself may give you so much of information so that immediately you can plan an aggressive management for this patient because it's got multiple areas are involved because of the proximal right coronary lesion and also it is supplying the posterior wall as well as the lateral wall because it is a right coronary dominant circulation. Whereas when you have an inferior wall infarction due to right coronary lesion, once again L3 elevation is more here. Now you have ST elevation less than 1 millimeter here, less than 2 millimeter here, a mild ST elevation in V5 and V6 and of course you have a concordant ST segment depression here. V2 and V1 are showing concordant ST segment depression. So when this ECG is like this, when the ST elevation in lateral leads is less than 2 millimeter, it is called co-dominant. Co-dominant means some portion of posterior descending artery is coming from right coronary artery, some portion of the posterior descending artery is coming from the left circumflex. So it's a co-dominant. So it is going to be intermediate risk infarction because in addition to right coronary inferior wall infarction, you have posterior wall infarction, but there is no right ventricular infarction because there is no discordant ST segment depression. So it is likely to be a distal right coronary lesion which is supplying the inferior wall, posterior wall, to some extent the lateral wall. So this could be a intermediate risk inferior wall infarction. So ST elevation in V5, V6 less than 2 millimeter. Whereas look at this ECG here and the patient has got more elevation in L3 than in L2. So you have diagnosed right coronary infarction, inferior wall infarction, but your lateral leads are not showing ST elevation, are not showing ST elevation at all. That means it is a left circumflex dominant. So in this circulation, you know, this is a left circumflex dominant because there is no ST elevation here. So that means your right coronary artery is likely to be not very long, giving rise to posterior descending artery. So in addition to that, he has got, you can see that here, it is likely to be a proximal right coronary because of the discordant ST segment depression here. Now, the summary of inferior wall infarction. So if you have ST elevation more in L3 than L2, it is right coronary. Having decided right coronary, look at lead V4r if it is present. If the lead V4r shows ST elevation, a lead V4r is not present, look at the discordant ST segment depression between V1 and V2. V2 is normal, V2 is showing significant ST segment depression, means it is a discordant ST segment depression. It is a proximal right coronary lesion. Inferior wall is involved, posterior wall is involved, and the right ventricle is involved. So it's a high risk inferior wall infarction. So if the right coronary L3 is more than L2, but there is a concordant ST segment depression, That means V1 and V2 are showing the same type of ST segment depression. There is no V4R ST elevation. So that means because of the concordant ST segment depression and chest leads, it tells you inferior wall infarction is there, post wall infarction is there. Because there is no V4R ST elevation, there is no right ventricular infarction. So this is a distal right coronary lesion supplying inferior wall and posterior wall intermediate risk. Whereas there is no ST segment elevation or depression, ST segment depression or elevation in your lateral leads, as well as there is no ST segment depression in your anterior leads, and there is no ST segment elevation in V4R. So this will include posterior wall infarction, right ventricular infarction, and it is purely only the right coronary involved distal lesion, only the pure inferior wall infarction, which is going to be low risk. Of course, whenever the L2 shows more elevation than L3, it is likely to be a left circumflex infarct. So in addition, having located right coronary lesion, you must also look at the lateral leads. If the lateral elevation is more than 2 mm, it is right coronary dominant. If it is elevated but less than 2 mm, it is codominant. If there is no ST elevation at all in the lateral leads, it is left circumflex or left dominant circulation. So here we have ruled, you are diagnosed whether the inferior wall infarction is right coronary or circumflex. Having diagnosed right coronary, we look at whether it is proximal or distal. Then we look at whether the posterior wall is involved. Then we look at what is the dominant circulation, whether the RCA is giving also rise to PDA and supplying a large area of infarction. So this type of information is available. So now we come to the inferior infarction due to left circumflex territory or left circumflex occlusion. So when the left circumflex occlusion is happening, because the left circumflex is coming on the lateral wall, your left side of the inferior wall is involved and not the right side of the inferior wall. Because of the left side of the inferior wall is involved, the L2 facing this area will have more elevation than the L2 which is on the right side. So that's why inferior wall infarctions, because of left circumflex lesion, will show more elevation in L2 than in L3. Of course, when left circumflex infarction is going to involve the posterior wall, once again, just like right coronary, will have depression in V1 to V3. Will have ST segment depression V1 to V3. So this will tell you that the posterior wall is involved in addition to inferior wall. The most important thing is here. In V4R, I will not have ST elevation. In contrast to that, in circumflex infarct, V4R will show ST segment depression and T wave inversion. ST segment depression and T wave inversion. Whereas in the right coronary artery, if I have V4R elevation, it is right ventricular infarction. If I have a normal ST segment and normal T wave, no right ventricular infarction. Whereas AVR is showing ST segment depression T wave, it is likely to be left circumflex infarct. Look at the CCG here. Here my L2 shows more elevation than L3, so it is likely to be a left circumflex infarction. So it is immediately tells you left circumflex infarction. When you look at the lead V4R, I have for the same ECG, you have ST segment depression and the T wave inversion. So the V4R alone, as now told you, that is likely to be left circumflex inferior wall infarction rather than right coronary inferior wall infarction. So the V4R is very crucial to diagnose right coronary versus the left circumflex. In the right coronary, whether it is proximal or distal. If lead V4 shows ST elevation, it is proximal right coronary. Normal ST segment and normal T wave, distal right coronary. If there is ST depression and the T wave inversion, it is left circumflex. So V4R is crucial in diagnosing these three types of occlusions. So now we try to know how to risk stratify a patient who has got left circumflex infarction. How to risk stratify that patient. So now you can see only two leads, high lateral wall, is showing ST segment elevation, and no other leads are showing ST segment elevation, means it is a purely high lateral infarction, even without posterior wall infarction, because you can see V1, V2, V3, they are not showing reciprocal ST segment depression. That means the posterior wall is not involved. It is this left circumflex involved is only on the high lateral wall. It is a low risk left circumflex infarction. There is no posterior wall infarction. Whereas in this ECG, in addition to ST elevation L1 AVL, you have significant ST segment depression V1 to V3. That means in addition to high lateral wall, I have associated posterior wall infarction. Because of that, this left circumflex infarct is likely to be intermediate risk because the two areas are involved now, high lateral wall and posterior wall. Now look at the ECG here. Anterior inferior wall is involved, L2 is more than L3. So inferior wall is due to left circumflex. In addition to that, L1 AVL as well as V5, V6 are involved. So I have additional lateral wall infarction. In addition to that, V1 to V3 shows reciprocal depression. That means I have associated posterior wall infarction. Very high risk left circumflex lesion because my inferior wall, entire lateral wall and posterior wall is involved because of this circumflex lesion. So multiple areas are involved in circumflex lesion. It's a very high risk left circumflex inferior wall infarction. So lateral wall is showing ST elevation and high lateral wall is showing ST elevation, and there is a depression in V1 to V3, a reciprocal change of posterior wall. Now, the another important sign to say that the left circumflex lesion is likely to be malignant and likely to be very high risk is looking at the sinus node abnormalities in left circumflex infarct. So you can see L1 and AVL are showing ST elevation. You are suspecting a left circumflex infarct. In addition to that, you look at the rhythm strip. There is a long RR interval, short RR interval, then long RR interval, short RR interval. So this is a classical sinus arrhythmia. So sinus arrhythmia means it is one of the sinus node arrhythmias. So this can happen in a circumflex infarction. It commonly happens in inferior wall infarction, sinus block or sinus arrhythmia, or all these things can happen because in 60% of people, sinus node is supplied by the circumflex, supplied by the right coronary artery. But in 40% of people, the sinus node is supplied by circumflex. So when that happens, the circumflex infarct is likely to have associated sinus node abnormality, either like this as a sinus arrhythmia, or sinoatrial block, or a severe sinus bradycardia. All of them you expect in inferior wall infarction. If you have a sinus node problem in circumflex infarction, it tells you your sinus node artery is coming from left circumflex. Not only that, when the sinus node artery is coming from left circumflex, most often it is going to be a very proximal branch. So it is going to be very proximal circumflex infarction or a very proximal occlusion of circumflex or even a left main lesion will produce a high lateral infarction or a circumflex infarction with sinus node abnormality. Once again, very high risk feature of circumflex infarct. So you can see the RR interval is quickening here, the RR interval is delayed here, telling you it's a sinus arrhythmia. Then how to risk stratify a patient with circumflex infarct? If you have only lateral wall infarction, without posterior wall infarction, without sinus node disease, no inferior wall infarction, it is a low risk. Only lateral wall is involved. Whereas you have lateral wall ST elevation, anterior ST segment depression means this patient, in addition to lateral wall infarction, he has got posterior wall infarction. So this is an intermediate risk. The patient may not have sinus node disease. Whereas a lateral wall infarction, in addition to anterior ST segment depression, which is also the posterior wall infarction, he has got the lateral, because he has got the sinus node disease as well as inferior wall infarction. That means it's a very high risk, the circumflex infarction, because inferior wall, entire lateral wall, posterior wall. In addition to that, the circumflex is likely to be a proximal occlusion because there is a sinus node disease, a very high risk circumflex infarct. So in this way, you can risk stratify a patient with circumflex. So now coming to the inferior wall infarction of the circumflex with RCCA, what are the ECG signs sensitivity and specificity. So if I have ST elevation more in L3 than in L2, and there is ST segment depression in L1 and AVL more than 1 millimeter, diagnosing a right coronary lesion, the sensitivity and specificity is so high. This L3 more than L2, sensitivity specificity more high. So having diagnosed right coronary lesion, if the V4r is going to show ST elevation, diagnosing proximal right coronary lesion once again will have a very high sensitivity and specificity. So if your ST elevation is in L2 is more than L3, but you have now ST elevation in L1, AVL, V5, V6 indicating lateral wall infarction, and there is a ST segment depression in V1 to V3 telling you a post-wall infarction, and these signs to predict left circumflex lesion is once again very high sensitivity and specificity. So contrast to interval or the LAD occlusion parameter ECG signs, the locating the left circumflex and right coronary lesions will have more sensitivity and specificity. So having diagnosed where it is obstructed in the 3 coronary arteries, namely the LAD, LCX and inferior wall, now we must know how many coronary arteries are involved. So whenever you have an inferior wall infarction, there is always a dilemma that whether the anterior ST segment depression V1 to V3 is going to be a pure reciprocal change of posterior wall, or it represent independent critical occlusion of LAD. So that is also possible. V1 to V3 showing ST segment depression means it could be a critical occlusion or non-ST elevation of left hand descending and a total occlusion of RCA. For that, you must see V1, the ST segment depression is confined only from V1 to V3 and not going beyond that. So when it is confined to V1 to V3, it is most often reciprocal of posterior wall. It is unlikely to be a critical occlusion of LAD. Whereas, so look at the lateral wall. Now look at the lateral wall. Here you have inferior wall infarction, anterior ST segment depression, and this depression is going beyond V3, V4 and V5, V6. So whenever this type of extensive depressions going beyond V3, you must suspect associated left coronary involvement. So this is how we can say that the patient may have additional left coronary lesion. How many coronaries are obstructed? Beyond the whatever we have told you regarding the perfusion abnormality, locating the coronary artery, and also the predicting the prognosis, now we come to and how many arteries are involved. Now we come to there are some information about the viability from the ECG which is not shown by coronary angiogram. For example, in this patient in inferior wall infarction, you have an established inferior wall infarction or a subacute inferior wall infarction shown by a pathological Q wave and a small R wave, which will tell me that in inferior wall I have a predominantly dead myocardium and a small R tells me there is a small healthy myocardium. So here the inferior wall is almost irreversibly damaged. But I also have some ST elevation and T wave inversion ANT.ST leads, V2, V3, V4. But contrast to this, I don't have a pathological Q wave here, but I have a well-formed R wave here with a coving and T wave inversion. Tells me in interval, in fact, in interval in the interval ST elevation infarction, I have more of healthy myocardium because my R wave is preserved. So if I do a coronary angiogram and RCA and left coronary are obstructed, my opening of the left coronary will yield me more benefit than opening of RCA. Why? Opening of RCA, you are going to only improve the blood supply to a predominantly dead myocardium. Whereas opening an LAD, you are going to open up an artery to a predominantly healthy myocardium. So the presence of the Q wave or the absence of the Q wave will decide which lesion to be revascularized. If the obstructed coronary artery is going to supply the healthy myocardium shown by the presence of R wave, it is good enough or it is very good for the patient to revascularize this area because you are going to save the healthy myocardium from going in for a permanent necrosis. Whereas when the patient already had a fully established scar, the opening of that artery to that scar may or may not yield benefit. Most often, it may not yield any benefit. Then we talk about what is known as the grades of ischemia. There are 3 grades of ischemia, where the ischemia can be a tall T wave alone, or the ST segment elevation is there, but it is not disfiguring the descent of the R wave, or there is ST segment elevation which is completely replacing the downslope of the QRS complex. So grade 3 ischemia is the one which completely replaces the downslope of the QRS complex, and it is a grade 3. So grade 1 is tall T wave with a mild elevation. L2 is ST elevation, but it is not completely disfiguring the downslope of R wave, whereas L3, the grade 3 ischemia, is completely replacing the downslope of R wave. So grade 1 ischemia, you have a very tall T waves, as I have told you, and there is no significant ST elevation, and you can see completely the whole complete downslope of the QRS you are able to see. So that means a grade 1 myocardioma, good prognosis. Whereas a grade 2 here, you can see lateral leads. I have ST elevation all right, but the ST elevation is not totally disfiguring one portion of the ST segment. So downslope of the QRS is well preserved with the ST elevation. Those are grade 2 ischemia, which is intermediate risk. Whereas look at here now. So you can see completely the whole downslope is replaced by ST elevation. I don't see the downslope at all. Everything is replaced by the huge ST segment. So this is a grade 3 ischemia, otherwise called tombstone ECG, because this ECG looks like tombstone, and majority of these patients will go under tombstone. So that's why it's called tombstone ischemia. Very bad prognosis, grade 3 ischemia, because of a very important pathological factor. This type of ST elevation happens only when the ischemia resistant Purkinje fibers are involved. So when the Purkinje fibers are involved, you know, it's a very high risk infarction, because extensive infarction only involved the ischemia resistant Purkinje fibers. Only when that is involved, you have an ST elevation like this, replacing the downslope of the QRS. So it indicates extensive myocardial infarction and greater severity of regional dysfunction. So even with a revascularization like PCI, the success is much less and the prognosis is very bad. So this is grade 1, grade 2 and grade 3 ischemia. So also I have told you so many things about the location of the coronary artery, and also beyond the coronary angiogram, ECG gives you very important information about viability, decision regarding revascularization. It will tell you the severity of that obstruction, whether it's a grade 1, grade 2, grade 3. All this information are not governed by coronary angiogram. It gives you so many information other than the obstruction shown by coronary angiogram. But it has got also limitations. There may be individual variations in coronary anatomy. If the patient has got previous myocardial infarction, the ECG changes may change. If the patient has got extensive collateral circulation, once again, you may not have typical changes. Patients who have undergone CABG, patients who have got left bundle branch block, and all these conditions, sometimes the ECG changes may not predict a classical site occlusion of a particular coronary artery. But please remember, except few exceptions, the localization is applied primarily to ST elevation ACS. The exceptions are left main occlusion where there is ST elevation in AVR, left main occlusion with a triple vessel disease, multiple ST segment depression lead AVR ST elevation, Wellen syndrome, symmetrical T wave inversion V2, V3, V4, and D Winters sign where there is a horizontal ST depression with a tall T wave. So these are the exceptions. Other than ST elevation MI, still you can localize a particular coronary lesion and send the patient for an immediate coronary angiogram. So ECG gives you valuable information about the presence, the extent, and also the localization, viability, and the complications of coronary heart disease. It also gives you valuable information which cannot be seen in ECG, I have mentioned before. So risk stratification, the important principles are, you must look at the two leads which are hardly looked at in normal electrocardiographic interpretation. That is lead 1, V1 and lead AVR. and because these two leads gives you the location of a particular coronary artery. So in anterval infarction, everybody will be looking at the ST elevation anterval. You must look at inferior leads because inferior segment ST segment depression in anterval tells me it is a proximal or mid LA deletion. If there is no ST depression in inferior lead, it tells me distal LA deletion, short LAD. If there is inferior ST elevation in anterval, I know it is a distal LAD deletion, but it is a long LAD and wraparound LAD. So what gives you very crucial information is not the anterior ST elevation anterior MI, it is the inferior leads. Similarly, in inferior wall infarction, you must look at the anterior leads, especially V1 to V3. If there is a ST segment depression, you know there is associated post-wall infarction. If there is a disparity between V1 and V2, you know there is additional right ventricular infarction. If the patient has got, in addition to that, lateral wall ST elevation more than 2 millimeter, you know right coronary is dominant. So what gives you crucial information in inferior wall infarction is anterior chest leads. So that's why in anterior wall infarction, look at inferior leads. In inferior wall infarction, look at anterior leads. And ECG can be Poorman's coronary angiogram if it is skillfully interpreted. 1 or 2 months back, June 10th, the great Heinz Wellen died, and at the age of 84 years. Whatever I told you in this lecture of localization is primarily his work, because he did electrocardiogram and immediately did coronary angiogram. So he correlated what will be the coronary angiogram findings when the ECG is like that, and he is a father of localization of coronary artery lesions from the ECG. It is his great work gave us this idea of locating the coronary lesions from the ECG, and world cardiology is mourning, and he has trained and influenced the cardiologists of 5 continents, including myself, and for him we will give our tribute, and this lecture is primarily because of his work. So thank you.